Well, let us now give you questions on the remaining conditions of the hip that you may get and you may be asked about. So this is the hip mop-up round. So let us summarize the viva on the remaining hip conditions. The first is congenital dislocation of the hip. It is also called as CDH or developmental dysplasia of hip or DDH. Let us say your diagnosis is congenital dislocation of the hip. First question is, why do you say so? So in a neonate, after all births, you should do an Ortolani and a Barlow test, which is positive on examination of a neonate. So you look for congenital anomalies and you do a Ortolani and a Barlow test in all deliveries to early detect congenital dislocation of the hip. When the child becomes older, you have restricted abduction and external rotation. If the child can walk, you will get a Trendelenburg gait, which if it is bilateral, it is called as the waddling gait. That means there is lateral bending of trunk on weight bearing, towards the side of weight bearing limb. If it is bilateral, it is on both sides. When the right limb bears weight, the trunk tilts to the right side. When the left limb bears weight, the trunk tilts to the left side. Wherever you suspect it, you must do an X-ray of the pelvis AP view. Here is the X-ray, and you must learn to draw two lines. The first is the line which connects the articular cartilage of both acetabulum. So this is the articular cartilage, and this line is called as the Hill-Jenner's line. This line is called as the Hill-Jenner's line. The second is a line which is vertical line drawn from the lateral edge of the acetabulum. This is called as the Perkins line. Now, a normal hip should lie in this quadrant, and an abnormal hip will lie in this quadrant. So this is the abnormal. So if the hip is in this quadrant or the neck is pointing towards this quadrant, it is a dislocation of the hip. The second sign is that this is a line which suggests the upper wall of the acetabulum. And with the Hill-Jenner's line, you draw an angle which is called as the acetabular angle. Normally, this acetabular angle less than 30 indicates that there is no dysplasia of the acetabulum. But if it is above 30 to 50 or 70, then there is dysplasia of the hip. So after this, the first thing you do on this is you draw the Perkins line, which is vertical from the edge of the acetabulum, and the Hill-Jenner's line, which is connecting the growth plate of both acetabulum. Here you see that there's a cross formed, and if the neck is pointing towards the outer upper quadrant, it is congenital dislocation of the hip. And of course, the size of this nucleus will also get shortened as compared to the size of this nucleus because it is outside the acetabulum. So the Hill-Jenner's, the Perkins line, the acetabular angle, this makes you diagnose a congenital dislocation of the hip radiologically. So these are the Hill-Jenner's and Perkins lines and the acetabular angle. In all neonates, you must do a Barlow test. Barlow means Baharlow, ability to dislocate the hip, that means push the head posteriorly. Then there is the opposite of Barlow test, which is Ortolani or Underlow. If you are able to do that, your clinical diagnosis of congenital dislocation of hip is done. So how do you treat it? You first reduce it by the Ortolani maneuver, and then you retain it by a broomstick plaster. If it is not reducible, then you do a open reduction and retain it by a K-wire. So, what are the factors that prevent closed reduction? The first factor is contracture of these pelvifemoral muscles. They don't allow this head to descend. The second is that there is an hourglass contracture of the capsule by the iliopsoas muscle, which doesn't allow it to go into the acetabulum. The third is the inverted limbus of the labrum acetabulare. The fourth is a filled acetabulum or a shallow acetabulum by fibrous tissue or by a hypertrophied ligamentum teres. So you deal with all these fractures and you reduce this hip. One important method of dealing with pelvifemoral contracture is shorten the femur so that the head can descend into the acetabulum. In old cases where you can't reduce, you do a pelvic support osteotomy. We've explained this to you quite well. For acetabular dysplasia, that means a high acetabular angle, you can do a Pemberton-Chiari or Salters osteotomy. For increased neck shaft angle, you can do a subtrochanteric varus osteotomy to improve the containment of the head. So now, after the congenital dislocation of hip, we deal with reduction of the posterior dislocation of the hip. Patient is under general anesthesia on the floor. You flex, adduct and internally rotate the hip. Give traction in this position to reduce. Then you take the knee outwards. And as you take the knee outwards, the head would go into the acetabulum. And then you extend it and plaster and abduction and external rotation for 6 weeks, followed by physiotherapy or gradual weight bearing. In an anterior dislocation of hip, you have the abduction, external rotation deformity. You flex it, there's lengthening, you flex it, you push the head back into the acetabulum, you adduct and internally rotate and extend, and you plaster the limb in that position. In central dislocation of hip, you can pull the head out by a traction pin, or you can pull the head out by a lateral longitudinal traction where the resultant is in the direction of the neck. After pulling it out, you may retain it by reconstructing the medial plate. In avascular necrosis, you do a core compression. If it doesn't respond, you have to do a total hip replacement. Similarly, with osteoarthritis, you do a total hip replacement. In septic arthritis, you do rest, traction, aspirate, and debride. You give antibiotics according to culture and sensitivity. There are 3 results. 1, the patient gets cured, you do nothing. If it's posterior dislocation of hip, you do pelvic support osteotomy. If it is bony ankylosis in a deformed position, then you do a corrective subtrochanteric osteotomy. If ground level activity is needed, you do an excisional arthroplasty plus minus pelvic support osteotomy. In ankylosing spondylitis, you do a hybrid total hip replacement where the cemented femoral component is not to be disturbed, but the uncemented acetabular component helps you replace the cup when it gets worn out easily. So, with this, you have to control disease activity and prevent limitation of movement by exercise. So this finishes our talk on the mop up of hip conditions.